and welcome to the workshop, How Rehabilitation Medicine Can Help Patients with Graft-versus-host-disease. My name is Sue Stewart, and I will be your moderator for today. Before we begin, I'd like to thank Takeda Pharmaceutical Company, whose support helped make this workshop possible. It's now my pleasure to introduce to you our speakers for today, Dr. Ekta Gupta and Dr. Megan Nelson. Dr. Gupta is an assistant professor in the Department of Palliative Care, Rehabilitation, and Integrative Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. She works with stem cell transplant patients, including those with graft-versus-host-disease, to optimize their functioning and quality of life. Dr. Nelson is the medical director of cancer rehabilitation at the University of Louisville James Graham Brown Cancer Center in Louisville, Kentucky, where they're doing the Kentucky Derby this weekend, I understand. She works closely with the Blood Cancers, Cellular Therapeutics, and Transplant Program. She assists patients in both the outpatient and inpatient setting, diagnosing functional impairments and coordinating rehabilitation interventions. Please join me in welcoming Dr. Gupta and Dr. Nelson.
Hello, everybody. This is Dr. Nelson, and thank you, Sue, for that introduction, and thank you for having us here to talk about how rehab medicine incorporates with patients with graft-versus-host-disease. So just a brief outline of what topics we're going to address today. One, we're just going to talk about the roles of the various rehabilitation providers available to patients. Then we will transition to talking about the different areas of your body that may be affected by chronic graft-versus-host-disease that can directly impact function in day-to-day life. We'll talk a little bit about how steroids impact function as well, discuss exercise, the importance of exercise, as well as the precautions we need to take when we are dealing with chronic graft-versus-host-disease, and also how to advocate for yourself, how to advocate for rehabilitation services to help you through the journey. So rehabilitation providers, there are many that fall into this definition. Many of us sometimes think about rehabilitation being more physical therapy or occupational therapy. We in rehabilitation see it as a large network of providers that help patients with their day-to-day function. So we will talk about physical therapy, occupational therapy, and speech therapy. But in addition to that, patients need adequate nutrition to be as functional as possible. We need good nutrition to make sure our muscles can work and our bones can be healthy. The treatment of these blood disorders and the graft-versus-host-disease can impact other things as well, like cognition, maybe foggy brain after some of the treatments, and rehabilitation can help with cognitive issues. And the mind and the body is very connected, and so emotional support services are critical as well. And we know if the mind is healthy, then it translates into being more active and address your needs, your rehabilitation needs. And there are many exercise specialists in the community as well, and it's helpful to find exercise specialists who have extra training in caring for cancer patients or patients with chronic graft-versus-host-disease. And also social support services are directly linked to rehabilitation. There are so many community resources available. As we know, the cost of care is high, and there are community resources that can assist patients with rehabilitation needs. So we'll talk first about physical therapy before we get to rehab physicians, which Dr. Gupta and I are. So physical therapy, the primary goal for these patients is to restore and maintain mobility and function and treat a physical source of injury potentially, but also the goal would be to reduce future issues, preventative rehab as we call it. So physical therapists work a lot on patients' ability to walk around their community or walk within the home, or if there's an inability to walk, to also use adaptive equipment or devices to help with mobility, whether that's a wheelchair, a walker, or canes. And balance can be affected by many treatments during a cancer or blood disorder treatment. And so physical therapy can work on balance so patients' mobility is improved. And physical therapists focus a lot on sit and stand function, whether it's sitting and going to standing from a chair or a bedside surface, or even commodes or toilets. So transferring between surfaces is important for physical therapy. The tools they utilize in physical therapy may be stretching, because tight muscles or tight joints require stretching and strengthening, utilizing equipment to help improve function and strength. Physical therapists can also do what we call manipulations, where they utilize their hands to help with muscle tension or joint range of motion. We also use devices that can help electrically stimulate muscles if there's weakness in certain areas, to stimulate directly those muscles to move and get stronger. And like I mentioned, there's a lot of durable medical equipment. That's the fancy word we use in insurance world and rehabilitation world. Durable medical equipment is just equipment we use in our home and our community to help us be as mobile as possible. And again, that may be a wheelchair or walker, cane or crutches. And also other medical equipment can be grab bars or elevated surfaces to help us move around our environment as best as we can. And you can find physical therapy in many domains within the medical community. There are physical therapists in the hospital setting if you're in the hospital, or in rehab facilities, outpatient rehab, which a lot of people traditionally think about. And then there are also some opportunities for home health rehab where physical therapy can come to you. So physical therapy, focusing on mobility and walking or managing your environment. Occupational therapy we'll move on to, and their goal obviously is also to restore function. And their goal is to assist patients with managing their day-to-day tasks and optimize independence. Independence can be affected by the underlying diagnosis or the treatments, but our goal is to improve independence regardless of the impairment that a patient may have. So we may treat the physical source of injury, but also help reduce future injury. Occupational therapy traditionally focuses more on the arms and the hands. So their tasks that they work with patients on is hygiene, such as brushing your teeth or bathing. They work on getting dressed, toileting, cooking and cleaning. So the day-to-day tasks that get patients through their day and take care of themselves and be as independent as possible. And they also ensure that patients, if they are working, have resources to adapt to ensure they can still do their jobs even if they have a deficit or an impairment, as well as encourage patients and show them maybe alternative ways to engage in their hobbies if something physically has changed or even cognitively has changed. So occupational therapy, they utilize tools similar to physical therapy, but they may just have a different focus and different goals, and again, focusing on the arms and hands. And their durable medical equipment they utilize includes shower benches or chairs. There are adaptations you can make to toilets and commodes to make patients be as independent as possible. I mentioned grab bars earlier. And then if feeding oneself is difficult, there are different ways to adapt those food utensils to, again, encourage independence. And just like physical therapy, occupational therapy is found in the same domains from hospitals, rehab facilities, outpatient, and within the homes. Speech therapy, their goal is to restore and maintain communication skills. But they do more than just the speech component of therapy. They also focus on swallow as well as cognition. And so they may utilize adaptive equipment if the voice is impacted, or strengthening the underlying voice. They may use technology as well. As I mentioned, they focus on the ability to swallow and the cognitive abilities to engage with your family, your loved ones, your friends, your environment, maybe at work as well. So they strengthen the oral and swallow muscles to help with communication as well as diet and nutrition. They utilize adaptive communication devices if the vocal cords or if the larynx or any other element that produces sound for ourselves is impacted. And just like physical therapy and occupational therapy, you can find speech therapy in a wide range across your community to assist you. So going to physiatrist, it can sometimes sound like psychiatrists, but physiatrists are rehab physicians, which Dr. Gupta and I are rehab physicians. We have specialty training within physical medicine and rehabilitation, which focuses on the goals that are listed there, maximizing patients' daily function and maximizing quality of life. And we utilize physical therapists, occupational therapists, and speech therapists to help our patients. But in the beginning, when we meet with patients, our first focus is to diagnose the reasons why patients have impairments that impact their function. So patients may have troubles walking, for instance, trying to peel apart all the different reasons why the patients may have impacted function. And so as listed in the bullet point, there may be reasons the cancer or the hematologic issue is contributing to impacting their walking, or the cancer treatments may have side effects such as chronic graft-versus-host-disease that impacts function. But there are a whole other list of reasons why patients may have functional issues, and it may be as simple as arthritis or neuropathy, lots of reasons that contribute to impaired function. So diagnosing all the contributing factors is our primary goal in the beginning, and then transitioning to assisting patients with creating reasonable goals that we can accomplish for each patient. We utilize a lot of tools to help we physiatrists or rehab physicians assist patients. Diagnostic evaluations, so we are able to order x-rays or MRIs or imaging to help diagnose conditions. Or we may use laboratory values, looking at whether a patient's anemic or not, or has other diagnoses that contribute to neuropathy, etc. We may refer to neuropsychology testing to assess cognitive status. We utilize driving assessments. Again, our mode is to try to improve independence. Vocational assessment to see if we can continue patients in employment. And we utilize our referrals, as I mentioned, including the rehab professionals, psychology assistants, etc. And we also have, as rehab physicians, the ability to assist with management of the underlying reasons for functional impairments by utilizing injections. For example, if someone has knee arthritis or back pain, injections to help treat underlying issues so they can be as functional as possible. And then we prescribe the appropriate durable medical equipment as well. You may find rehab physicians in various domains as well. It may be from when you're in the hospital to outpatient arena. So now we will be transitioning to focusing on the different areas of the body affected by chronic graft-versus-host-disease. And we will tackle each of these areas, domains of the body that can impact function. So I will turn it over to Dr. Ekta Gupta for the next slides.
Thank you, Dr. Nelson. That was a really great overview of the roles of the different providers that we work with and what we do. So the first area that I'll be speaking about is the skin and fascia. Fascia is basically the connective tissue that surrounds our nerves, bones, ligaments, etc. I do want to point out that we did pick a few areas to discuss, but there are many more areas in the body that can be impacted by chronic GVHD. So we'll just try to go ahead and focus on these 4 areas. So skin involvement is the most common manifestation of chronic GVHD and can affect about 90 to 100% of patients. There are 2 types of skin manifestations, the lichenoid and sclerodermatose. You may hear your physicians kind of differentiating between the 2 for you. The lichenoid generally presents as a rash, and it can affect the mouth and the vaginal areas as well. If you look at the picture, you can see in the top left corner, they say lichen planus, like chronic GVHD, and it shows a pink or red scaly rash. And then, as I mentioned, the other type, which is the sclerodermoid or sclerotic, can cause skin tightening, thinning, blistering, ulcers, loss of sweat glands, and change in joint mobility. If you look at the picture, you're kind of seeing that at the bottom left corner, and it shows how skin tightening can decrease joint mobility. There are other effects, too, of chronic GVHD on the skin. It can affect your hair and nails. It can cause rippled skin. If you look at the bottom right picture, we see brittle nails that are very commonly seen. We also notice that there can be oral ulcers, dry mouth, skin sores, and hair loss, which we'll talk about a little bit later. Swelling can be initially seen in the arms or legs, especially when the fascia is involved. Common joints affected are the wrists, shoulders, ankles, and hips, with the joints further away from the body tending to be affected first. The skin changes are often seen in both hands and then can progress over time. So as one would expect with these areas of the body affected, we see differences and unfortunately impairments in movement and mobility. Daily hygiene and tasks can be affected as well when we have difficulty and changes with our hands. And then job and hobbies are also changed because we're unable to do the roles or function as we expect. So what are the treatments? There can be stretching, splinted modalities, and these have to be very carefully done in order to monitor your skin integrity. We always encourage patients to avoid pools when you have open wounds, unless you're doing specialized therapy. There will be a talk after ours by physical and occupational therapy that will be discussing different modalities and treatments that the therapist can do to help with these changes that we see with skin involvement. You may hear your physicians, especially your BMT team, talking about steroids, phototherapy, or UVB light that could be explored as well. So if we move on to the next slide, we see a few ways that we can monitor the effects of chronic GVHD on the skin and fascia. If you look at this slide, it starts with the shoulder, and then there are also basically minimal ranges of motion. It goes from includes the shoulder, elbow, wrist, fingers, and foot dorsiflexion. So one is the minimal range of motion that we're looking at, and it progresses to full range of motion of the shoulders at 7. If you see with elbow flexion is what 1 starts at, and then it goes all the way to 7, which is full elbow extension. Same with the wrist, we're looking at being able to reach full wrist extension and flexion. And then for the foot dorsiflexion, we would like to see the ankle come all the way up. Dorsiflexion is bringing your ankle up, and then plantar flexion is bringing your ankle down. Generally, the changes due to skin GVHD cause you to keep your ankle down, and ideally we want to try to stretch the Achilles tendon to be able to bring our ankle up. If we look at some of the oral side effects of chronic GVHD, we can see quite a few changes in the mouth, unfortunately. You'll see sorry, 1 second here. In part A, you'll see erythema, which is that redness that's being caused in the gums. Sometimes you see redness on the tongue as well, which you can see in the picture on the right and under section A. As I mentioned earlier, you can see lichenoid lesions as well in the mouth and the vaginal area. And you're seeing kind of those changes in part B, where you're seeing the discoloration with the white changes along the gums as well as the soft tissues. You can see ulcers developing, which you're seeing an example of on this person's lip in part C. And it can also happen in the oral mucosa. And then you can see mucoceles as well as sclerosis occur, which are D and E. So having GVHD in the mouth can impact your swallowing, your speech, and there are different ways to treat it. As Dr. Nelson had mentioned, there is speech therapy. And in the picture on part E, you see an example of somebody being measured and then using the TheraBite. So this is a way that speech therapy can be involved to help you work on jaw range of motion when you start to have sclerotic changes. We often also consult our dietitians to assist us with recommendations regarding our diet and how to modify that. And sometimes that may mean using a soft diet, taking smaller bites, using a straw. And so there are different strategies that both speech and dietary work together to provide to help patients dealing with this oral chronic GVHD. On the next slide, we talk about ocular GVHD, or how the eyes are affected. Unfortunately, we know that this can affect our vision, and this can cause issues, especially with driving, and then how to kind of modify when we're not able to drive. So that's an area that physical occupational therapy can also assist with, as well as actual driver's evaluation. So here in Houston, we have a company that we work with that we refer our patients to when they're needing assistance with driving due to changes. In the picture, you can see the different effects. So there's grade 0, grade 1, and grade 2 chronic GVHD, and you can see the changes that we're seeing in the eye. On the next slide, we talk about the effects of the cardiopulmonary system, so the heart and lungs related to chronic GVHD. In this x-ray, you're seeing changes that have occurred, as well as a fluid or pleural effusion, as we would call it. So fluid in the lungs, as well as changes to lung function, can occur. Unfortunately, as we see these changes, we find that patients have a harder time with breathing, and then your muscles also become weaker over time. In severe cases, you can also see constriction around the heart related to chronic GVHD, but there is cardiopulmonary rehabilitation that can help patients. Generally, cardiopulmonary rehabilitation is a specialized area. There are therapists that are working on your breathing while monitoring different areas such as your heart rate, your pulse ox, and they have you doing a variety of different things to work on your breathing, being able to take deep breaths and watching how you do with this. It's generally a supervised activity that slowly allows you to progress in your function under close monitoring. In the next slide, we talk about steroid-induced myopathy. This is very, very common because many of the GVHDs are treated with steroids. So steroids are helping decrease that inflammation that you're feeling from the GVHD, but in turn, the steroids also do have side effects. So generally, when we look at the literature related to steroid-induced myopathy, we're seeing a weakness in the proximal muscles, especially the hip flexors, the neck and shoulder muscles. It is a slow onset of weakness, and it's generally dose-dependent. So for patients that are on chronic steroid use at high doses, we see more of these effects. You'll find that sometimes you'll notice that you have a difficult time going from sitting to standing, And that's generally related to that weakness that we're seeing in the hip flexors, specifically the iliopsoas muscles. And then we also see it related in the quad muscles as well. And so what do we do when that happens? Well, first we talk to our oncology team. So we ask them, is there a way to treat the GVHD at a lower dose of steroids? Are there alternative medications that we can try to see if this helps? Often we notice improvement as the patients are weaned off of steroids or put on a lower dose. We also start rehabilitation. So the physical therapy team can work on sit-to-stands, exercises that help strengthen those hip muscles, and occupational therapy can work on strengthening the shoulders and the neck muscles. By doing so, we counteract the effects of the steroids on these muscles. So the literature shows you actually have to do a combination. Ideally, you need to treat the steroid myopathy by decreasing your steroid dose, but you also have to do a moderate level of exercise in order to really see an improvement and counteract the effects of the steroid-induced myopathy. So what are some precautions that we need to keep in mind when we're talking about working with therapy, especially in the setting of chronic GVHD? So blood levels. I know that several people have anemia, which is having a low red blood cell count, and that can make you tired, feel faint, dizzy, or just overall feel weak and have difficulty doing activities. So we need to be aware of what our blood levels are and set goals based off of where we generally live with our blood counts. So if your hemoglobin is normally 7 to 8, you may feel some of these effects. And there are strategies by physical and occupational therapy to help you conserve your energy so that you can focus on doing the activities that you would like to do with the awareness that your blood levels are low. We often also see neutropenia, which is a low white blood cell count. This puts you at risk for infection, and it is very commonly seen after a bone marrow transplant. Your bone marrow team has generally put you on antibiotics or antifungal medications that are prophylaxis to avoid obtaining an infection. But what can you do with the therapist? So it's being aware, wearing gloves and a mask when you're in a therapy setting. It should not restrict you from going to outpatient therapy, but you just need to be cautious. Always wash your hands after you do your therapy, and then try to be aware that if somebody is sick near you, that you have your mask on, and then request that they have their mask on too. I think during the COVID era, this has become a lot easier as most patients are masked when they're in the therapy setting, both outpatient and inpatient. The other thing to keep in mind is thrombocytopenia. So low platelet counts put you at risk for easy bruising and bleeding. There have been several studies that have shown that actually a count of less than 10,000 or so still does not cause major events, but we want to be conscious of this. So depending on where you are in the community, sometimes the physical therapist will limit what activities they do with you depending on your platelet counts. There's more and more literature that is appearing about this, and so I always recommend you have a talk with your physician regarding cutoffs for platelet counts. Here at MD Anderson, we're a little bit more liberal with our platelet counts, meaning we will allow you to do TheraBand, which are those stretchy bands that have some resistance, even with platelet counts of 10 to 20,000. Sometimes in the community, they cut you off at about 50,000, and I think that's a discussion that you do have to have with your team to help decide what's best. If you see bruising by doing the resistance bands, obviously you want to hold off and maybe change so you're doing a lighter resistance band. If you've ever noticed, there's a lot of different colors of resistance bands, and that's basically a change in the level of resistance that that band is providing. So we can start low and then try to advance the resistance band and see how you respond. I think one thing to keep in mind especially when you have low blood levels of all three of these, is to be very conscious as to your risk of falls. That's the one thing that we try to avoid, because falling when you're thrombocytopenic can cause you to break a bone, to have blood in the brain, and other issues that require immediate intervention. In addition, keeping in mind that your blood counts are low should make you conscious about falling. So when you have anemia, you don't want to try to get up and go right away. You may need to give yourself a moment to stand up and then pause before you try to do your next activity. I mentioned this earlier, but other things to keep in mind. So when we have skin breakdown with GVHD of the skin, we should avoid pool or water exercise, and then avoid stretching that pulls or tugs at a wound. Last but not least, in terms of things to keep in mind, weakened bones. So often related to treatments as well as steroids, we can see osteoporosis as well as something called avascular necrosis of our bones, especially the heads of our femur. These are the long bones in our legs, and they do a lot of the weight bearing for walking. And so it's very important to kind of be aware of your bone integrity and bone health. Resistance training can help you build bone integrity. But as I mentioned, if your counts are low, you need to do this with the advice of your physical therapist and physician. If you're having pain in your bones, you need to have it evaluated before you start exercise programs. We need to know if you're at high risk for a fracture, because then we will limit some of the activities that we try to have you do in order to modify and help you just work on bone strength, but not put you at higher risk for fracture. So next, I'll pass it back over to Dr. Nelson, who will kind of finish up, and then we'll move forward with questions.
Thank you, Dr. Gupta. So essentially, in summary, the next few slides is just to reiterate that rehabilitation services can help maintain function with the goal of not losing function rather than waiting to lose function. Hopefully prevent, as we said, worsening of function, but also our hope is always to restore some function. And utilizing the various rehabilitation providers. If you are able to be evaluated by a physical medicine and rehabilitation physician like Dr. Gupta or I, we can help diagnose conditions that affect your function. Physical therapists can help you work on your mobility, again, whether it's within the home or out in the community. And occupational therapists primarily work on the arm and hand function. So if you're having difficulties with your activities of daily living, bathing, dressing, toileting, hygiene, occupational therapists would be the right avenue to request a referral to them. And speech therapy to work on swallow as well as your vocalization and communication. Also, speech therapy is wonderful for cognitive dysfunction, whether, again, like I mentioned earlier, if it's foggy thinking after the treatments that you've endured. So advocating for yourself and knowing potentially whether you need physical therapy, occupational therapy, and or speech therapy. And if you feel like you would benefit from physical medicine and rehabilitation physician, there is a link that we've included in the slides that you can click on that link and put in your zip code and look for a physical medicine and rehabilitation physician near your area. And asking your medical providers, your oncologists, they may be aware of a rehab physician that they've worked closely with throughout the years. And I always think it's super helpful to talk to your support network, whether that's your loved ones, friends, or other patients and support groups, or online support. There are so many ways to advocate for yourself, and they may have great tips and tricks to help you with your rehabilitation needs. We thank you so much, Dr. Gupta and I, for listening to this presentation, and we will open it up to questions.
Thank you so much, Dr. Nelson and Dr. Gupta. That was very instructive, I think, in helping us understand how physical medicine rehabilitation specialists can help us as we're dealing with things like graft-versus-host disease. As a reminder to the audience, if you have a question for Dr. Nelson or Dr. Gupta, use the Ask the Question box on the left side of your screen. Chat that in, and we will try to get to as many questions as we can. The first question, I think, relates, Dr. Nelson, to the last slide you showed. You indicated how to find a rehabilitation medicine specialist. How do you find one that understands graft-versus-host disease?
Wonderful question. If you're in more of an urban area, reaching out to the list of rehab physicians available, you may want to contact one of them. If they don't online show that they have specialty in cancer rehabilitation or bone marrow transplant patients, I think reaching out to whichever one you can contact. A lot of times our rehab professionals, our rehab doctors are connected. We're a fairly small community, so if that individual, that physician, does not have training in patients with chronic graft-versus-host disease, they will be able to reach out to their colleagues in the community or beyond their community and still hopefully be able to assist you.
Thank you. Dr. Gupta, this person wants to know that given the concerns people have about COVID these days, is it possible to consult with a rehabilitation specialist or an occupational therapist online as opposed to in person?
Thank you. Yes, it is. It just depends on the setting in terms of the state you're in. So at MD Anderson, we still do virtual visits, but I think that's changing per state. So it may be something to look into in terms of state guidelines. I would suggest, as Dr. Nelson said, trying to reach out to a rehabilitation provider near you and then asking that question whether or not it's possible for them to refer you to an occupational therapist who does virtual visits.
All right, thank you. Dr. Nelson, this person wants to know whether exercise or having a physical therapy or occupational therapy before and or during treatment, in addition to after treatment, can reduce the risk of developing GVHD or the severity of GVHD.
I'm not aware of the interventions during that time frame necessarily preventing chronic graft-versus-host disease. But what we do know is it can help with the severity of the symptoms, such as reduced joint range of motion. The earlier we can be involved with stretching, that is helpful to prevent further tightening. But also I think it's important that rehab providers can take notice earlier of reducing range of motion or reducing function that may be occurring, and then the rehabilitation providers can notify the oncology physicians earlier and say, we're seeing reduced function, and that may prompt earlier interventions from a medical and rehabilitation standpoint.
Thank you. Dr. Gupta, this person wants to know whether you have any insights into edema as a manifestation of chronic GVHD. Her family member's edema has not responded to initial treatment, but has been referred to a nephrologist due to elevated kidney values. Is there any particular rehab considerations related to edema that is greatly impacting his mobility?
Thank you. So that is a complex question. I think there are important things to rule out when we address edema. Seeing the kidney doctor, for example, to see if it's related to the kidneys is important. Ruling out any blood clots that could be causing edema in that specific extremity, if it's just one extremity. Generally, if we're seeing the same level of edema in both legs, it is usually not a blood clot, but that's always something that's important to do. Then the next question that I would ask is there anything going on in terms of lymph node involvement? Are we seeing edema related to lymphedema? If we're not seeing edema related to lymphedema, then does elevating our legs on pillows at night, for example, help? If it does, have we tried compression stockings? There are several different levels of compression stockings, meaning they apply a different pressure. So a lot of the in-hospital ones, basic over-the-counter compression stockings start at 10 to 20 millimeters per mercury. So it's a consideration to start there and then see if it helps. If it doesn't help enough, you may need to see a specialized provider, such as a physical therapist, who deals with this edema and can provide you with more specialized stockings. So there are interventions, but I think it's important to figure out the cause of the edema first.
All right, thank you. Dr. Nelson, does daily or regular incentive spirometry help prevent lung GVHD? And what about aerobic exercise for the same issue?
Yeah, thank you for that question. Incentive spirometry, I am not aware either whether that helps prevent lung GVHD. However, incentive spirometry is very helpful on maintaining lung function as best as you can. And it also is a preventative technique to help reduce risk of pneumonias. So again, I'm not aware of it preventing chronic graft-versus-host disease in the lung, but I think it's a really beneficial technique to enhance your lung function. And if you do develop graft-versus-host disease of the lung, despite using incentive spirometry, you're maximizing your lung reserve, which is helpful going forward. Dr. Gupta, are you aware of incentive spirometry preventing graft-versus-host disease?
I'm also not aware of any literature supporting that. I think, and I may have skipped over this, but in terms of the answer to that specific question, no, I'm not aware. One thing that I didn't mention was seeing a pulmonologist who may perform pulmonary function tests, and that can also give you an idea as to what type of restriction you may have in terms of your lungs. And sometimes they can then help direct whether or not incentive spirometry may help you maintain that lung function. Does that make sense?
Yes,
Sure.
Absolutely. Thank you for adding that.
All right. Thank you for that. Dr. Gupta, this person is from a small place in Europe, and there are no specialists for GVHD. She wants to know whether lung GVHD rehab resembles lung rehab after COVID.
Thank you. So it is slightly different. And I think that's, once again, as I mentioned, those pulmonary function tests would be useful in seeing exactly where you have the restrictions. So what type of rehab might benefit you based off of your pulmonary function test. I don't want to say trying to do some of the exercises that you may do related to COVID could not help you. I just don't know if I could say that they're exactly the same, if that makes sense. I don't know if you have any further input, Dr. Nelson.
I agree with you. I think it really is determined based upon your lung function, and then the rehab professionals knowing whether you have what we call either restrictive or constrictive lung function can then determine the best rehab intervention. And so I do think pulmonary rehabilitation will be helpful, and our pulmonary rehabilitation providers are used to treating both different types of lung conditions, so they would be able to tailor it specifically for you.
All right, thank you. The next question for Dr. Nelson. I've seen ads for deep tissue massage machines for $100 or more. Are these useful, or should I steer away from them?
So deep tissue massage can be difficult when you have skin graft-versus-host disease. several layers of the skin can be involved with the graft-versus-host disease. And sometimes what that translates into is the skin is more friable or not as strong as it once was. And a deep tissue massage device could impair the integrity of the skin. And I think it's really important to kind of think about it person and patient independent. If an individual has had wounds, skin wounds because of chronic graft-versus-host disease or reduced joint range of motion, then we know that level of graft-versus-host disease is more advanced, and I would think it would be a risk to use a deep tissue massage device in that scenario. Now, in a milder level of chronic graft-versus-host disease, it may be better tolerated, but still there's, graft-versus-host disease can be somewhat of an inflammatory component too, so a deep tissue massage may enhance inflammatory component. Dr. Gupta, do you have any other additional input on that?
No, I would agree.
All right, thank you. Dr. Gupta, as long as you're on, I'll direct this next question to you. This listener said, I've been diagnosed with fasciitis, and it really is affecting my quality of life. What do you suggest to help with this?
So there are different treatments depending on the location of fasciitis. And so stretching can definitely make a huge impact. So for example, if it's plantar fasciitis, while it might be related to the graft-versus-host disease, we can treat it kind of similarly to what we might treat it in other patients. So sometimes splinting can be an option too, to provide like a static stretch onto that area. And then working with therapy on strengthening as well may help you.
Thank you. And I'll mention again, I think Dr. Nelson mentioned it earlier, that the next workshop that follows this, there'll actually be some demonstrations of what splinting and some of these other interventions are for those of you who are interested. Dr. Nelson, how does GVHD interact with neuropathy? Does it make it worse?
So graft-versus-host disease can directly impact our nerves, which if our nerve health is compromised can cause neuropathy where you may feel numbness, tingling in certain areas of our body. So graft-versus-host disease, whether it directly affects the nerves or the other way it can affect the nerves is by affecting the tissue, the skin, the fascia, all the muscles, even all the tissues that surround nerves. If those get more fibrotic and tight, it can also put pressure on the nerves. So chronic graft-versus-host disease, again, can have a direct impact on the nerves itself, but then also a secondary impact by affecting the tissues around it. So it is connected for sure.
Thank you. Dr. Gupta, this person wants to know if there are any medications that you should not use once you've developed neuropathy.
So do you mean in the setting of vitamins? I guess what I would say in the setting of vitamins when we think about neuropathy is you should get your levels checked. Just taking vitamin B complex over the counter is not always appropriate because you don't want to be overdoing it basically, and you don't want to have abnormally high levels of vitamins that might contribute. And then that actually can contribute to your neuropathy if you're abnormally high. In terms of other medications, there's possibly side effects related to medications, but in general, there's not one that I think I would say that you specifically need to avoid per se. I don't know, Dr. Nelson, if you have any thoughts on that.
I agree with you. I think what's also important in addition to not overdoing vitamins is to make sure your other medical conditions are well managed, especially the other medical conditions that can contribute to neuropathy. So, for example, if you have diabetes as well, we know diabetes can contribute to neuropathy, so being very cognizant of taking your medicines for diabetes to ensure that doesn't contribute to neuropathy, or if you have a thyroid disorder, making sure that is well managed so it doesn't exacerbate your neuropathy. I agree with everything else you said, Dr. Gupta.
Thank you. Dr. Nelson, as long as you're on, I'll direct this next question to you. This individual wants to know whether prophylactic swallowing exercises are helpful to maintain swallowing function in the setting of GVHD.
That is a great question that I'm not aware of the literature regarding preventative exercises for swallow, but this is me speaking on my own thinking, is that it would be beneficial to maintain muscle strength, especially when you have oral graft-versus-host-disease involvement, to try to maximize and maintain function. I think about it for all the rest of our muscles in our body. When we want to keep strength in our arms and our legs, we have to continue doing exercises and maintain strength. I would think it would be the same for those swallow muscles, but again, I'm not up to date on the speech therapy swallow literature in chronic graft-versus-host disease on that specific question.
All right. Dr. Gupta, can you explain what TENS therapy, TENS, is and when it's used?
Sure. So TENS is transcutaneous electrical nerve stimulation. So what it is basically a series of pads that are applied generally onto the muscles that are tight or having spasms, and it sends electrical impulses through the pads. Like you're obviously the machine is hooked to a pad. Sorry, I should have clarified that. And then it says electrical impulses to the muscles. So the idea of TENS is that it can help kind of stimulate different endorphins and try to decrease the pain that we're having as well as the spasms in muscles. It can be pretty effective for many patients, especially for that pain management. We'll use it a lot for low back pain. However, I think the caveat with TENS for GVHD is once again the same issues that Dr. Nelson had mentioned related to skin. So if you have skin GVHD, that's something to consider because those electrical impulses may feel differently and they may transmit differently through fibrotic or thickened skin and thickened fascia compared to non-thickened areas. So I generally use TENS when somebody is complaining of that kind of spasms. I'll use it in the upper extremities, the neck, the paraspinal muscles. But we have to be really careful about what their skin is or what their skin looks like and feels like in that area. And then the other thing you can do is try it at a low frequency and see how it affects the skin. Are there skin changes that we notice? What is the pain level with the application? So does the pain actually improve or does it worsen? Luckily, it is a topical pad, so you can remove the whole TENS unit. But that would be my suggestion. I would just be very, very cautious regarding the skin GVHD and the use of TENS.
Thank you. That's helpful. Dr. Nelson, can you explain what scrambler therapy is and when it is useful?
So I have not used scrambler therapy on a particular patient at this point, but scrambler therapy is somewhat similar to TENS unit in the sense of it's trying to prevent painful signals getting to the brain by distracting the brain, essentially. So distracting those painful signals and readjust your perception of stimuli coming to the brain. So I have not had a specific patient use scrambler therapy at this point for chronic graft-versus-host disease. I'm curious, Dr. Gupta, if you've had a patient use scrambler therapy yet.
So we do use scrambler therapy here at MD Anderson, but it's the same issue with chronic GVHD. It's the skin GVHD that makes it a limitation, I would say. Generally, when I've referred patients for scrambler therapy, it's related to severe peripheral neuropathy or central neuropathy that's causing severe pain in an extremity. And I've had very good results, but I think once again in the setting of GVHD, you need to be aware as to the changes of the skin, the fascia, that sclerotic thickening, and how that might be affected if you try such a modality.
All right, thank you. And Dr. Gupta, while you're here, this person wants to know if someone has sensitive skin and they have graft-versus-host disease, what are some of the best tips on how to exfoliate the skin safely?
To be honest, I'm actually not sure if I know the answer to that question. I mean, because generally we say avoiding anything with, irritants in the face wash, lotion, things like that. I always advise mild, very mild lotions like using CeraVe. If you're using a face wash, using one with sensitive skin. I'm not sure regarding exfoliation. Dr. Nelson, do you have any thoughts?
I'm unaware as well, but I think what would be really helpful is to ask your primary provider, your oncologist, based upon your level of graft-versus-host disease, if your particular skin would tolerate like a very light exfoliation ointment or cream or wash, and that way they could better direct you specifically.
All right. This individual wants to know if you have any thoughts, any comments on red light or near infrared therapy for skin or muscle. Dr. Gupta?
So to be honest, I do not know very much about that. I know that there is some growing areas of use when we're talking about muscular changes. So I think they're looking at it for using use in the quads and things like that. But I have never used it clinically, and I'm not sure if there's any studies that have looked at safety in our GVHD population. I don't know if you know more, Dr. Nelson?
I do not. I am unaware of that research either.
Well, thank you. And with that, I'm afraid we're going to have to wrap up the workshop. This has been an excellent and very informative presentation. And again, I do encourage those that are interested in this topic to watch the next presentation, which is actually going to demonstrate some of these therapies. I want to thank Dr. Gupta and Dr. Nelson for their time and for this wonderful information. And I want to thank the audience for some terrific questions that have been submitted.